Well, I'm going to go ahead and get us started. I think, Nolise, if you think we're ready.
Absolutely. Yes.
Great. And my name is Karen Pank. I'm the Executive Director for the Chief Probation Officers of California, and I really appreciate everybody joining us today. I am going to turn this over to Nolise Edwards, who's a special consultant for us and has been working very closely on these issues related to CalAIM. And specifically probation's involvement in a lot of the onboarding of this new program related to justice involved individuals. And I know she's been in a lot of meetings and talking with a lot of folks, as many of you probably have as well. So we're very excited to have this presentation to try to make some sense out of what might be out there and what answering some of your questions. So with that, I will turn it over to Nolise.
Right. Thank you, Karen. Good afternoon, everybody. Thank you for taking the time out this afternoon to spend an hour with us. As Karen indicated, I am the special consultant to CPOC, and one of the key initiatives that I do work on is the CalAIM initiative, justice involved piece, specifically for how it intersects with probation. And so, you know, as these discussions continue to heat up locally, we thought this would be a good time for you all to, you know, for us to pull together this presentation for you all and to hopefully answer some of your questions. And for those questions that we can't get to or we need to go back and get a response, we will make sure that we do that. So I'm not going to take a lot of time. I'm going to turn it over to Bren, but I did want to let you all know again to put your questions in the chat. We're going to be monitoring the chat, and some of the questions we will answer. They will be able to answer throughout the discussion, but at the end, there will be also a live piece for Q&A. So hopefully you can also get some of your questions answered at that point in time as well. Bren, turning it over to you.
Yes, ma'am. Thank you so much. Good afternoon, everyone. I am Bren Manaw, and I am with the consulting firm of Health Management Associates, or HMA for short. We are deeply engaged in California with several projects supported with state opioid response funding through California Department of Healthcare Services. I'll share a little bit more about those here in just a moment and how that is relevant for you all. And I'm the project director for both of those projects. I am pleased to be joined with my co-presenters today, David Panish, who is the president of California Health Policy Strategies, and one of your esteemed colleagues, Cal Remington, whom of course many of you know or know of by reputation maybe, who is a retired chief probation officer from Ventura, as well as other county assignments. So I'm going to just walk through quickly the projects that we're currently engaged in. And again, the context for this is because we are already working in these counties under these projects, supporting them with technical assistance, focusing on the justice involved population, we are able to really dig in, do deep dives in these counties to support conversations, discussions, planning efforts around the CalAIM implementation specific to the justice involved population. And of course, you all with probation have a very critical role in this rollout. So the County Touchpoints project is focused on that intersection of child welfare, substance use disorders or addiction, and then the behavioral health systems and the justice system. So we have multidisciplinary county teams that are involved in this learning collaborative. We're a year and a half into it now. They're doing some great work finding ways to better address the needs of these individuals in those counties. And you can see the participating counties listed there on the screen in front of you. Butte, Kings Lake, Los Angeles, etc. And you know, this recording and this deck will be available to you all for reference afterwards as well. We also now are over 3 years in to our very large scale, what we call for short, the MAT Jail project, which is a learning collaborative currently of 31 participating counties. We've had 37 participating over the life of the project. That one really focuses on access to MAT and other evidence-based treatment in the county jails, but we're also looking at that larger continuum within the community and the justice system, including reentry from jail, people who are under community supervision or participating in drug courts. So again, in all of those counties as well, if you are from one of those counties, we are available right now to talk with you, engage you around the issues of CalAIM that we're going to be talking about today. And lastly, but not least, we asked for and got permission from DHCS under our current contract with them to do a much deeper dive around TA in these three targeted counties, where we're really focusing on the managed care plans in those counties to help them better understand the justice and involved population, how they move around the healthcare system and social support systems in the county, and to help them better understand and plan for their responsibility as MCPs under CalAIM. So similarly, we are available in those counties for extensive TA as well. And as Karen and Nolise know, it is within our scope under County Touchpoints to provide support in TA currently to professional associations such as CPOC. So we will continue to be available to work with Karen and Nolise to plan additional forums such as the one today. Our interest is really helping you all really understand the implications of this and how you can best leverage and maximize the opportunities coming through CalAIM for additional and path through additional funding, but also to understand your role and responsibilities. And we're just really invested doing whatever we can to help with that. So at this point, I'm going to invite Cal Remington to say a few words about the context for CalAIM as it pertains to probation. And then David Panish will pick up from there with the rest of the training. So pleasure to be with you all today.
All right. Thank you, Bren. Yeah, so first let me say it's my pleasure to be here. I know there's a lot of you out there, and I'm thinking a number of people out there are people that I've worked with in the past and I call friends. I know Steve Adami from San Francisco is out there, and I haven't seen you, Steve, for about 5 or 6 years. But anyway, it's nice to be with this large group today. When I work with CalHIPS and HMA, one of the purposes is they, in the last couple of years, both those organizations have felt they needed to get a better understanding of probation. And so they've really gone out of their way to do that. And so I kind of fit in helping them do that. So when I was looking at this CalAIM, my particular view on this is that it provides tremendous opportunity for probation. So much of what services can be funded through this are things that either probation departments have done to some degree or have wanted to do, and just haven't had the resources. CalAIM will provide those resources. So that's the real opportunity. I like the targeting of reentry. I also like, but this is certainly going to be a challenge. I like that it really, to make this work, county systems are going to have to work well together. And I know that that in many counties that is the case. But it's going to have to be a closer relationship than I think we've had before, and I think a little closer than just maybe a partnership. So I think it's going to take a tremendous amount of work. People are going to have to be willing to share more, and that's not always easy. I told someone I wasn't going to tell a joke because I'm not very funny, but there is a definition of collaboration that I think that might be appropriate here, and that is collaboration is really more than just a partnership. It really requires people to work closely together. My dog is causing problems here. And so the definition really is that to work that closely together, it's an unnatural act performed by non-consenting adults. And so I think you'll all want to take work with NCPOC. I know there's going to be a lot of work, a lot of sharing. The same goes for the technical assistance. You're all going to need a lot of technical assistance. So I think in summary, Greg, I think this provides tremendous opportunities for probation, tremendous opportunities for offenders on probation coming out of our institution. I like, again, the fact that there's a priority on probation and the sheriff and the behavioral health and community-based organizations working together. It's going to change this when it's finally implemented, is going to change the system, and it's going to change the system in a real positive way. Lastly, I would say that the timing in relation to 823 young people coming into county system is really ideal, because I think by the time you start releasing a lot of those folks, this system will be set up. So I think you all have a lot of work ahead of you. There's got to be a lot of sharing. You've got to work closely together, but the potential is there. And so I would say together you can make it work, and together you will build a really good system in all the counties. So Brent, I think that's it as kind of an overview. So I'll turn it back to you, please.
And I believe we'll pass the mic to David at this point. And Cal, thank you so much for being here and for your comments. We really appreciate it.
You're welcome, Brent.
Thanks, Cal. Brent, you want to go to the next slide and let's see what's. So hi, everyone. I'm David Panish. I'm the president of California Health Policy Strategies, or CalHIPS, and have worked with many of you over the years. I have to tell you that from where I sit, it's so often that when we do these health reforms, and CalAIM is a Medi-Cal change, when we've done these things in the past, the justice system folks always get left out. I mean, it's just one of those things that always happens. People forget that those that are involved, that are justice involved, also have serious behavioral health and healthcare needs, and also needs that relate to their social determinants of health, which we'll talk about a little bit. And this is a program that calls out the justice system folks specifically. So that's very, very different and very new. Just at a high level, here are some of the key components that we'll be talking about today. You know, it's a new approach. The focus of CalAIM is really on those that are the most vulnerable, hard to reach, and costly Medi-Cal beneficiaries. And what we know is that most of the people that are being served in the justice system are likely to be Medi-Cal eligibles. Secondly, that this is, as I've said, it's going to include specific elements for the justice involved population, and we'll be talking about what those are today, including the implementation of a pre-release Medi-Cal application process in county jails and youth correctional facilities. So again, to the extent that probation is managing those youth correctional facilities is something that need to be paying attention to, and we'll be talking about that a little bit. There's also a set of targeted Medi-Cal services that would be provided in the jail 90 days prior to release of the offenders. This is still pending federal approval, but we're optimistic it's going to happen. In addition to that, there are these two new programs that come out of CalAIM that we'll be talking about. Enhanced care management, which is, think of it as case management on steroids, and also these things called community supports. So these are building on what has been coming out of whole person care pilots, and some of your counties may be familiar with that. But it's really emphasizing non-clinical non-clinical services like housing and food that we're using the Medi-Cal system to help pay for. The last overview point I want to make is that the funding for this is coming in a different way. So in the past, funding for these kinds of programs has come through counties. In this time, the funding is really, most of it is coming through Medi-Cal managed care plans. And most of the folks in probation not used to dealing with Medi-Cal managed care plans. So this is going to be a whole new world, which makes the collaboration that Cal talked about even more important. Medi-Cal managed care plans also don't know much about the criminal justice system or probation. And so it's one of those things that we're going to have to work through in order to make this work. So let's go to the next slide. So key issues for probation. There are two new mandates that are important, state mandates. The first one relates to Medi-Cal enrollment processes. And so for juvenile facilities, this is something that juvenile facilities will need to partner with county social services to develop a process for making sure that kids are enrolled into Medi-Cal if they're eligible. And that kicks in January 1st of 2023. So about less than 8 months away. There's also a requirement for jails and for juvenile facilities of a warm handoff to county behavioral health. So if a kid is receiving behavioral health services in a juvenile facility, it's supposed to be a warm handoff to county behavioral health. And the implementation again for that is January 1st. Second issue is that I think it sort of overlays this effort is how probation will access and coordinate with the new Medi-Cal managed care plans for those enhanced care management services and community supports. And we'll be talking about that through the presentation. Now, a lot of you are going to say, well, a lot of this is great, but we don't have the capacity right now. There are all these new services, new benefits. We don't have those in our county right now at the level that we're going to need it. So there is funding for capacity building, and we'll be talking about that too. So these are things like how to build IT data exchange systems, workforce recruitment, training, and additional facilities for behavioral health. So how can probation get involved in some of those decision-making processes that will be going on at the county, at the local level, county level, to ensure that that probation needs and the needs of justice system folks are connected. Let's go to the next slide. So at the outset, I said that there are some specific high-risk populations that are specifically called out in CalAIM. And these specific populations are going to be eligible for enhanced care management, which we'll talk about in more detail. But there are specific populations that are required. They're mandatory populations under this new law. And so these are populations that you kind of would expect. So individuals who are experiencing homelessness, high utilizers, the people who are going in and out of hospitals and emergency rooms, individuals with serious behavioral health issues who are at risk of institutionalization, complex and kids and youth with complex physical and behavioral health issues, kids that are in foster care system, which is another flag for probation, people who are transitioning from nursing homes to the community, people who are at risk of institutionalization or long-term care. But they added in one that really kind of caught me by surprise. And they specifically called out individuals who are transitioning from incarceration, who have significant complex physical or behavioral health needs and may have other social factors influencing their health. So these are the people that probation is serving. Let's go on to the next slide. So how does CalAIM define them? So there are two parts to this test. So first is that you have to have people who have been incarcerated or transitioning from incarceration within the past 12 months. Second, the enhanced care management requires coordination with the state prison system, local corrections departments, including probation, courts, and the local county jail system to identify members to ensure connections once they're released from incarceration. Let's go to the next slide. So in addition to transitioning within the last 12 months, you have to have at least one of the following conditions. So it's not everybody coming out of prison and jail and juvenile facilities. You have to have at least one of the following conditions: chronic mental illness, substance use disorder, chronic disease like Hep C or diabetes, intellectual or developmental disability, traumatic brain injury, HIV, and pregnancy. And these are kind of defined, but in broad strokes, those are the categories that we're looking at here. And I think most of us would believe that there's a large percentage of the incarcerated population that will fall into those categories. Let's go to the next slide. As I mentioned earlier, and we'll talk about this a little bit later too, there are two important mandates that are included in CalAIM. One is the requirement that for people who are coming out, that there's this requirement that jails and juvenile facilities assist inmates and juveniles with the medical application process. So you don't have to guarantee that everyone who's eligible gets Medi-Cal when they leave, but you have to, the mandate is that there is a process that facilitates that to the greatest extent possible. And that kicks in January 1st. And there is some funding that's now available through the state that we'll talk about later that would help with the planning process for that. Let's go to the next slide. Second mandate is, again, that a requirement that there's a warm handoff. Sometimes they refer to as a facilitated referral and linkage to county behavioral health for individuals that are coming out of jail or the juvenile facilities who are receiving behavioral health treatment. That requirement kicks in no sooner than January 1st. So it's a little different. It's still a mandate that kicks in fairly soon. Let's go to the next one. So now we're going to talk a little bit about enhanced care management and community supports. So these are kind of the keystones of CalAIM, because it's an acknowledgement that just providing medical services the way we've always done it, where people show up to a doctor and ask for care, isn't really going to work for a lot of our populations that are hard to serve. So in order to improve that, one requirement is that you have to have this enhanced care management, which is, think of it as very intensive case management where people are providing face-to-face services. And this is a requirement that kicks in, and implementation begins January 1st. So for the justice-involved population that we defined, we talked about earlier, January 1st is when it begins. Let's go to the next slide. So I already mentioned that, and we can talk more about this, but enhanced care management is that face-to-face collaborative approach. Case managers are supposed to work with the primary care and behavioral health providers. They're supposed to engage clients and family members. And there's also a requirement and an encouragement that the people who are providing this service have lived experience. And we know for the justice-involved population, trust is such an important factor in engagement, that finding ways to include people who have that lived experience is something that's going to contribute significantly to the effectiveness of enhanced care management. Let's go to the next slide. So enhanced care managers are supposed to do outreach and engagement. They're supposed to do comprehensive assessment, case management planning, coordination of care, health promotion, transitional care. So as people might coming out of jail or a juvenile facility or coming out of a hospital, they're supposed to be involved in that. They're supposed to connect with members with both the offender population, but also families that are connected to those clients. And then finally, the enhanced care managers are supposed to provide coordination of and referral to community and social support services. So it's kind of a guide, a navigator of the complex systems that we've got, and maybe also a friend. Let's go to the next slide. So it's very nice that we have case management, but I think all of the data that I've seen is that if you just do case management, even if it's really intensive, it's not going to be as effective unless you can really address some of these underlying needs, such as housing or food. There are 14 pre-authorized community supports that are, these are these non-clinical services that can now be provided through Medi-Cal managed care plans to address some of these needs. So there are 14 of them. I'm highlighting a couple of them here that are most significant for the justice population. So these are things like housing transition navigation. So these are services where you can provide assistance to helping connect people with housing in their communities. There's also housing, the support for housing deposits. So this can include one-time payment of security deposits, setup fees, deposits for utilities. There's funding for tenancy support. So sometimes you'll get someone into a unit and they need help in navigating the problems with landlords or with neighbors. So this is to help them maintain their housing and so they don't get evicted. One that's really exciting to me is a benefit that would provide up to 6 months of rent for people who are coming out of hospitals or correctional facilities for up to 6 months. So that's a really big one. And we can mention that a little bit later in the discussion. There's medical respite for people who are coming out of jail or out of a hospital who might need 15 days of special services while they're recuperating. And then there are these sobering centers. So this is an alternative destination. So some counties have already started these sobering centers. CalAIM is a way of paying for it through Medi-Cal. Now, the one thing I want to say about community supports, and maybe this is on the next slide, let's see. Just before we get to the InReach, the community supports have to be sponsored by the Medi-Cal managed care plans, and the plans cannot be required to provide them, but they get to opt into them. And so, depending on your county, you can see which plans, Medi-Cal managed care plans you have, and which of these community supports have been opted into. The plans can also, they're not locked into stone, they can change them later and add more as they build capacity and as they sort of respond to community needs. So it's different. Each plan has a different set of community supports that they have agreed to so far, and it's worth knowing what they are, and we can talk about that more later. So another key element in CalAIM is this 90-day jail InReach. So it's jail and, I should say, jail and community and youth correctional facilities. So this is still something that's under discussion with the federal government. And so you all know that currently there are significant restrictions on what Medi-Cal can pay for someone that's incarcerated. And so this is carving out a very narrow window that says that the federal government could provide reimbursement through Medi-Cal for a set of services that are going to help prepare people or help plan and coordinate services for them when they leave. So these are things like providing the assessment and assessment and planning for when someone is going to be transitioning from incarceration back into the community. So you get care management, you get some consultation services, you get some limited laboratory and radiology. There's an ability to provide 30-day supply of medications when they leave. That's very important. And then there are additional services that are provided within the jail. So as for post-release. So, and these are things like the meds, but also durable medical. So someone needs like a wheelchair, that would be an example of durable medical equipment. So this could be a major game changer because it provides that connection point and an engagement point using the jail as a way of facilitating that transition into the community for people with medical and behavioral health needs. Let's go to the next slide. So these are, we know that going from 0 to 60 or, is going to be a challenge. And so there are a couple of different plans and funding that's available to help build capacity, because we know most communities do not have the infrastructure, they don't have the workforce, they don't have the IT systems that are necessary to really make this work in the context of Medi-Cal. So two parts that are very important. The first one is that the Medi-Cal managed care plans that again are responsible for in large measure for implementation of CalAIM has $1.5 billion over 3 years to help provide the funding in their communities for these kinds of activities. So that's IT infrastructure, workforce, established quality measures, planning processes, all related to this. The Medi-Cal managed care plans are expected to work with local partners, which could include justice system folks, on gap and needs assessment and planning processes in order to make this work. Let's go to the next slide. In addition to that, so the first part is funding that's provided through the Medi-Cal managed care plans. The second part is this PATH funding. So PATH is an acronym, because we love our acronyms, it's for providing access and transforming health, or PATH. What's important to note here is that there's $561 million that's specifically targeted for justice involved populations over the next 5 years. And again, this is funding that would go to it could go to counties, it could go to probation, it could go to community-based organizations, sheriffs, adult correctional facilities. It goes to almost anyone except for the managed care plans. So one pot of money is targeted for managed care plans. One pot of money is targeted for community efforts. So funding can be used for staff training, to help workforce recruitment, billing processes as we sort of move into this world of integrating with Medi-Cal managed care plans. Providers have to become providers of enhanced care management, and community supports are going to have to contract with Medi-Cal managed care plans. And there are all kinds of requirements that go along with that. Let's go to the next slide. So this is a little bit more about PATH funding. 150 million has already been approved by the federal government. There's an additional 410 million that's still awaiting federal approval, as I understand it, but we're all optimistic. And let's go to the next slide and you'll see how some of this is going to roll out. So of the 151 million, it's going to be available in 2 rounds. The first round is some small planning grant money, and the department has already put out the Department of Healthcare Services put out about 10 days ago their guidance on how the first round is supposed to work. This is money that is really intended for probation, sheriffs, and county human services departments, and the Department of Corrections and Rehabilitation as well, to begin planning for how they're going to implement that first mandate that relates to Medi-Cal eligibility and enrollment processes for people who are coming out of jails and juvenile facilities. Counties can get a maximum of $400,000 depending on how many correctional facilities they have in their counties. So we can talk more about that. And then round two is sort of the bigger grants that will provide for implementation of the plans that are developed. Let's go to the next slide.
David, this is Nolise. Can I just pause here for a second? Because I just wanted to make sure if there were any other questions at this point on this PATH funding that we have from the audience, because we did have some questions about the requirements and the timing and all of that. So I didn't know if anybody at this point wanted to ask any questions before David moved on to the next slide. If not, if you don't want, you put it in the chat, or you can, raise your hand and we can call on you and ask that question now. Chief Keen.
Thank you, Nolise. I appreciate it. The opportunity to ask a question. Hey, Cal, how you doing? Quick question for you, David. So when we've met here in San Mateo about this, we're fortunate that we engaged in whole person care. So a lot of the infrastructure here already exists for some of this work. But we were told that some of the requirements around this funding is pretty strenuous. Do you know much about that process and what the oversight is, and what the responsibilities are in terms of just, how do you have to respond back in terms of just, whatever, how I gotta put it, whatever hoops or whatever we may have to jump through to show that we actually can utilize the funding, or that it's well spent?
This first round of PATH funding is fairly narrow, but I think we haven't seen the actual application form yet. The department, as far as I know, they haven't released it yet. The guidance that they put out does suggest that, it doesn't strike me as being overly onerous if we're talking about that narrower piece. So, if we're talking about the round one, which is focused on helping juvenile facilities and jails develop this Medi-Cal eligibility and an application process, it seems, to me anyway, it seems fairly straightforward. I think what you might be hinting at, though, is that a lot of the CalAIM transition issues are building off of a different model. So in the case of whole person care, that was really a county model. The counties built those whole person care pilots. They developed contracting systems with community-based organizations in order to implement it. And they have a structure that was really modeled around county processes. So now when we move to CalAIM, they're now taking that pilot model to scale, if you will. And but they're using Medi-Cal managed care as the funding mechanism. So that means that as we integrate what community-based organizations are doing into Medi-Cal, they have to meet all of the Medi-Cal requirements, which are strenuous. And, for example, I was talking to one community-based organization, and they were kind of shocked that they're going to have to meet HIPAA requirements now. Well, I was like, well, what's that? That means all kinds of security requirements. They're going to have to, they will need IT systems so that they can identify who they're serving and what the outcomes were of the people who were served. So sometimes those are different requirements because we're using a different funding system for it. That's the bad news. The good news is that Medi-Cal provides an ongoing funding source that we've never had before. Usually these pilots You know, great, they do great work. And then when they're done, they're done. And I've been involved in a couple of these pilots, as some of you know. We hope that they would continue. They don't. So by incorporating them into the Medi-Cal managed care system, that's the road of the future. That's where the money is, and it's going to be bumpy. Does that hit some of the high points of your question?
It does. I mean, I think you went exactly where I was going to go with step 2, which was about some of that transitional work with the systems needing to speak to each other, some of the processes that needs to be in place, the training that comes along with that. So no, thank you. I think you've hit on exactly what I was questioning. So thank you very much.
Chief Keen, this is Bren Manaw. As you know, probably San Mateo is one of the counties participating in our Jail Mat Learning Collaborative, and
Yes.
we're happy to connect with you on some additional support and TA on this issue if that's of interest to you guys. So you can just let us know. We're happy to help.
Well, I can answer that today and say yes.
All right, we'll reach out to you then. Happy to do that. Thank you.
No, these other questions, or you want to?
There is a question, David, in the chat on this. It says, it's from Nikki. I don't want to blow your last name, so I won't say it. I apologize. Can you please elaborate on the round 1 allocations per facility per county? I understand the max per county is 400,000, but sheriff and probation, where is it at? I lost it. But sheriff and probation offices, mine is cutting off, and I don't know if you can see it. There's a request up to 50K for the first facility, 25K for the second and subsequent facilities. In El Dorado, the sheriff runs 2 jails. Our probation department has 1 youth detention facility. Would we be able to each request 50K for our initial facilities?
I believe that the way that the state is structuring this is that there's 1 application for each county. So the probation, sheriff, social services all need to work together to put that together. And as part of that plan, they have to figure out, you know, how much each, you know, I don't know if the plan needs to say that probation gets X amount, but they have to say how the juvenile facility is going to be, how the juvenile facility will be planning to meet the mandate. So what is it that they're going to need, you know, and they're going to have some specificity on how the funds will be spent. That's the way I would understand the application process based on the guidelines that they released.
Okay. That's the only question I see thus far on the funding, David. So we can go ahead and finish up the rest, and then in the last few, there are some other questions on whole person care and all of that you all may want to answer.
So I think we all know that for the justice involved population, housing is a huge problem. We just wanted to highlight that there are a number of new resources, one-time funds that are being allocated that were allocated in last year's budget. These are identified here. I can just zip through them here. I think many of you are aware that there's this behavioral health continuum infrastructure program, which again could include supportive housing or short-term residential treatment programs, sober living center, sober living housing. Same for community care expansions. These are also for board and care facilities that can serve this, that serve this population. There is some one-time money also through Medi-Cal managed care for housing that establishes this housing and homelessness incentive program that requires counties to develop a plan to on homelessness that will track to CalAIM's mandatory population of focus that's homeless and the homeless population there. HAP is another of the housing programs. And then there are these adult reentry grants from the board and from the BSCC folks that I think people are aware of. Let's go to the next slide. Okay. In the governor's budget, there's an extra, this is still proposed. So, you know, we don't have a state budget yet, but $50 million has been allocated just for startup costs for justice system. And then 1.5 billion for this behavioral health bridge program. And in the context of the governor's care court proposal, you'll hear a lot about this behavioral health bridge. So let's see, going to the next slide. Finally, in the budget, there's almost $100 million for the expansion of MAT program, so medication assisted treatment, which we care a lot about because our team has been doing a lot of work to get the word out on that. So we're excited about that. Next slide. So a couple of things here. This is fairly at the 100,000 foot level, but implementation is like tomorrow practically. So there's a lot of work that needs to be done. We know that expectations are, we have to be realistic about them. We know that it's not gonna on January 1st, everything is not going to be perfect, but it really needs to start January 1st. That's what the requirements are. So as these are complex systems, they're going to they really need to involve justice system folks like probation, because believe me, if you just leave it to health people, they're not going to get it right. And it's important for CPOC to be represented in the committees, in the local committees where these decisions are being made. So getting together at the Board of Supervisors level with managed care plans, county health and behavioral programs, all of those folks really need to be at the table. But in the discussion about jails and juvenile facilities, I mean, probation, you guys are as you know, you're the ones that are most knowledgeable about how those systems work and how, particularly when people are released and they're on probation supervision, how are they going to be connected? So we talked about the mandates for juvenile facilities. Keep in mind that addressing homelessness is going to be key to the effectiveness. Oftentimes the programs on how, in the same way that justice system practitioners kind of get left out of the health world, in the housing world, justice system also seems to be often lost, even though many of our folks are experiencing homelessness. Planning processes also should be thinking about how parolees and PRCSs who are coming out of state prison are addressed, and of course, people coming out of state hospitals. As sort of the planning processes begin, and it'd be interesting to hear from you about where different counties are in this. I mean, generally what I'm hearing is that it's just starting now, but we ought to be thinking about how can CalAIM be used to support probation's long-term goals? How does it reduce? And these are from a political point of view too, and sort of selling the value of what can be offered here to Board of Supervisors and decision makers. How can this reduce homelessness? How can it reduce recidivism and further incarceration rates? What kinds of things should probation be worried about? I mean, if I suggest that one worry should be that probation gets left out of these conversations, because I've seen this over and time and again. That sometimes probation is not at the table when important decisions like this are made, because people forget. And then how will enhanced care management be organized? So, these are systems that are going to have to work hand in hand with probation in the community as individuals transition from incarceration back to the community. How will those services be coordinated with current probation services for case management and supervision? Well, we have a lot of food for thought here. So we talked about path funding already. data collection and outcome measures, under Medi-Cal, there are all kinds of requirements that the Medi-Cal managed care plans have for ensuring that they're able to report on what's going on with their Medi-Cal eligible members, and as the CalAIM systems are integrated, they're going to have to respond to that. So, and the last one is implementation and ongoing management. This is not a day one project. It's not a pilot. This is an ongoing effort, and there will need to be a local governance structure to ensure that there's support for this initiative and that it can be changed and adjusted and improved as it moves forward, as we get some learning experience. There's contact information for me and Bren, and we can throw Cal in there too. Cal under the bus as well. When we get stuck, we always bring in Cal. So
great, David. Brenda, you all want to answer? There's a couple of questions in the chat. We have a few minutes left. And for those, there are some questions that I see coming into the chat that we may not have a response for, because like in the one about HIPAA and others is because they are currently working on that in terms of how this will be applicable for sharing of information that's legal, not legal. How do you, get around HIPAA and all of that? And so, we will continue to provide you with any information that we get from that. But there are a couple of questions in there, Brendan or David, if you guys want to answer those, or do you want me to read them, or how do you want to do this real quick?
you want to just call them out for everyone, and then we can tee them up.
Yeah, so there is a question. What would be the recommendation for the non-whole person care counties that don't have the infrastructure systems? For some reason, my chat cuts it off.
Want me to, I can read it. I
Yeah,
can read it.
Elise. Thank you.
Yeah, mine shows. So what would be the recommendation for the non-whole person care counties that don't have the infrastructure and systems in place? Setting up data systems obviously is very costly and lengthy. So, we obviously have some counties on that are whole person, some that are not. Any thoughts on that?
The first step is to sit down with the board of, staff from the board of supervisors or with the CAO's office to see how they're organizing with respect to CalAIM and their Medi-Cal managed care plans in that county. Each county, as you know, has a different model of managed care. And so in some counties you have, like in Sacramento, we have 5 Medi-Cal managed care plans. San Diego has 7. Some only have, like in Orange County, only have 1. So it's a lot easier. But beginning that conversation with the county folks and with the Medi-Cal managed care folks, that needs to start immediately. And to see, for the justice population, remember, it kicks in January, but it has started already for many populations, including individuals that are experiencing homelessness. That started January 1 of this year. So we're now building off of that. Even counties that have whole person care pilots, most of them did not address the justice population. So almost all counties are going to be starting to develop that infrastructure for the justice involved folks, I believe anyway. And those, again, it's going to be a long road to do what's necessary to make it fully functional. Bren, what am I missing?
Well, there was a question about county systems. So I was talking about sort of the individualistic nature of that for each county, depending on who the key players and champions are in that county. I think you called out, some typical or expected partners, but there's a lot of flexibility here around who comes to the table to plan and execute on this. So there's not really a prescribed team or formula that counties have to follow here.
And I would just add, Bryn, to that question, because I saw that earlier as well. One thing to put in context for those of you who are listening, and thank you for kind of joining this conversation. And it's so important to be educated about what this is about, even if you don't know how your county yet is maybe moving forward in this, because I think, as David said so well, probation could easily be forgotten in part of that conversation. So, you know, in some counties, people may be looking to you to lead the conversation as it relates to what the county's response might look like as a part of the justice involved population. And in other counties, it may have already kind of been established in the non-justice involved population, and you'll just need to be sure that you can find out how, you know, that you'll be connecting to that. So, you know, we're trying to put out as much information, because what we have seen when new state initiatives come down, regardless of where they come from, which department or agency, you're best to be armed with the knowledge about it so that you can go into those rooms locally and have the necessary conversation. So I hopefully this is likely to have spurred, I'm sure, more questions than answers in some cases, but it's the place to start. And you know, can't thank David and Bryn and Cal as enough, because there's, I think, going to be a lot further discussion on this, because it's not going away. It's not a one-time scenario, which is another thing we wanted to be sure to get out to the field. So that's, I just wanted to add that, because I know we were getting close to the end, Elise.
Yeah, no, we are at the 2:00 spot. So yes, Karen, that's exactly, you're exactly right. And I think the reason why, you know, we did the food for thought, and thank you, Brendan, David, and Chief Remington, is because we wanted you all to have that in your sphere as you are starting to meet with your counties. These are the things we want you to consider and know. And then when questions arise around these areas, please come back, please let us know. You know, I put my information in the chat as well. And so that, you know, we will be able, CPOC will be able to know what's happening at the local level, what's being discussed, what is it that we need to make sure that we do for you on our end to help you with your local conversations with the county. And just know that, you know, we are involved in the Justice Involved Initiative Advisory Group. And one of the main reasons that we are messaging is to ensure that, you know, there is some understanding as to what probation does, how this should intersect, you know, collaboratively, and, you know, so that DHCS can also understand what it is that we do as they look to further this initiative. And so I think we are at the end. I don't know, Brent, if you have any last comments for this, but
Yes.
I do want to thank you all.
Yeah, thank you for the opportunity. This really is an opportunity to elevate our whole system if we can get all the wheels on track and pulling in the right direction. And we really want to support you all with that. We know you're under siege all the time with everything you're expected to do. So we're trying to kind of clear the path for you. Along those lines, as I said earlier, we're happy to provide additional training or forums for questions. And probably next week, we'll be releasing a very in-depth guide to CalAIM implementation specific to the justice involved population that David largely wrote, and which we really appreciate. And we will, of course, share that with Karen and Nolise to push out to you guys. So thanks for your attention and time today. And as I said earlier, just let us know if or how we can be of assistance. We're happy to do it.
Great, thank you. Chief, Chief Ken, I didn't know if you wanted to say anything last before we end.
Oh, only that again, I think this is a tremendous opportunity. It's going to take a lot of work. It's going to take a lot of help. A lot of people are going to have to work very closely together. But yeah, it was my pleasure to be here. If anyone can make this work, it will be probation. And so I'm just kind of looking forward to seeing some of the spectacular programs that come out of this. So good talking to everyone, and thank you, Nolise and Karen and CPOC for letting us present today.
Great. Thank you all. Have a great rest of your day. We will get the PowerPoint out to you directly after this, and all of our contacts will be on there. Have a great one, everybody.
Take
Thank
care,
you.
everybody.
Thank you.
Bye-bye.
Thank you.